Good evening, everybody. Thank you for joining the RPA Women and Babies and Canterbury Hospital GP Antenatal Share Care Program orientation session. My name is Alex Woodywis and I'm the Central and Eastern Sydney PHN Antenatal Share Care Project Officer for the RPA in Canterbury region. I'm joined tonight by a couple of co-facilitators and I'll run through the introductions in a moment. Please note this session will be recorded and available as a source of revision and learning for new registrations, who will then be able to confirm the viewing through completing a form. Please post in the chat your name if you notice that your login name doesn't accurately reflect who you are, as attendance certificates and antenatal share care points will be applied following the presentation. Before we continue, on behalf of CESPN, I would like to acknowledge the Aboriginal and Torres Strait Islander peoples of this nation as traditional custodians and sovereign people of the land across which we work, play and live. We recognise their continuing connection to land, water and community and pay respect to elders past and present and emerging, and extend this to any Aboriginal people joining us this evening. So a few housekeeping rules. The meeting etiquette. You are welcome to leave your cameras on or turn them off. Please do mute yourself as it is a jam-packed session tonight. So we request that all questions are submitted through the chat box. If we have any time at the end of the session, we can open up the mics and you can ask your questions. However, if we're running short on time and not able to answer all the questions, I will note them down and provide a response in a follow-up email. If you're having any connection problems or sound issues, please log off and then log back onto the session. This seems to help most of the issues. If you have any questions during the Engage outpatients, we will endeavour to answer them while Hannah is with us. You should receive a copy of the PDF slides at the end of this program, this session tonight, and it contains all active links to relevant resources. So a little bit about the model of care that it's available to women deemed low risk. So the GP Antenatal Share Care Program promotes continuity of care through sharing clinical responsibility for pregnant women between a GP and hospital-based services under defined guidelines and protocols. The program aims to provide women with better flexibility, choice and continuity of care, cater for preferences and needs of women from a range of cultural and diverse backgrounds, enhance the skills of GPs caring for women during pregnancy, and promote communication between GPs and the participating hospital. Just some roles and responsibilities. So CESPN work collaboratively with Sydney LHD and South Eastern Sydney LHD to deliver 3 antenatal share care programs across our region. So there's RPA Women and Babies in Canterbury Hospital, the Royal Hospital for Women, and St George and Sutherland Hospital.
Or is that making her listen to me? I want to hear the.
Sorry, I'm just going to mute the participants. Thank you. Each antenatal share care program has an advisory committee, which is comprised of local GP advisors, hospital staff, and CESPN staff. Each committee meets quarterly and is responsible for the clinical governance of the program, ensuring appropriate standards of antenatal care are maintained. They advise on the operation of the antenatal share care protocols, monitor identified or emerging risks, provide feedback on the program initiatives, and assist with developing educational priorities. So recognition as an antenatal share care GP, there is an application. First, the orientation session, which you are all attending now, as well as the online first trimester screening model. Once completed this, please send your certificates to antenatal share care at cespn.com.au so we can update your profiles accordingly. Following this, an appointment letter will be sent to you on behalf of CESLHD and CESPN outlining the appointment agreement, and your name will be added to antenatal share care GP lists, both at RPA and Canterbury Hospital. Just go back to our introductions to Mel Tulloch, who is our GP shared care midwife, Hannah Coffey, the CESLHD e-referrals project officer, and Dr. Effie Alexandrados, who is an antenatal share care GP and the chair of our advisory committee. So maintaining GP antenatal share care recognition, you're required to accrue a minimum of 6 CPD hours, formerly 12 CPD points, relating to antenatal postnatal education for the triennium. Currently, we're in 2023-2025. This is accrued at a pro rata rate too. So if you join this year, you'll only need 2 CPD hours. So we have a range of CPD events across the year, which is promoted in our newsletter and our assessment events page. There's also online learning modules, and you're also welcome to attend any postnatal and antenatal education outside of our organisation and just send it through to us and we can update your profile accordingly. So there are a range of resources and they're available. Sorry, I'll just let some people in. It is the responsibility of GPs to ensure that you're referring to the most up-to-date clinical resources. We have shifted over to all online resources to try to avoid old or outdated resources being used. So please ensure you're referring to the most up-to-date files by checking the published date on the website against the date on the information sheet. If they don't match, you'll need to clear your browser. We always recommend referring to websites linked in these sites. Please don't download the resources and save them to your desktop, and never check the websites again because they do tend to get updated quite frequently. So please look out for the Antenatal Share Care e-newsletter. This is our primary point of communication between hospitals, PHN and GPs. This is distributed quarterly. You are automatically subscribed and you cannot unsubscribe if you are a recognised antenatal share care GP. If you aren't receiving this, please check your junk email or contact me to check your email address is correct. However, if you are attending tonight's session, you will have received email communication, so it's more than likely your email address is correct in our system. There's antenatal record cards. There's some inconsistencies, or women may have multiple yellow cards as a result of telehealth consultations with the hospitals, and midwives may start a new yellow card during a telehealth consultation session. If you're in need of any antenatal record cards, please use Finsbury Green. They are free of charge, and a minimum of 250 cards is required. You'll only have to pay the postage and handling fees. With referral forms, we have moved to online e-referrals. So please use the Sydney Local Health District Women's Health Maternity form. Hannah will go through this in more details in the coming slides. For any feedback and complaints, SLHD and SESMN are both committed to ongoing quality improvement with the Antenatal Share Care program. We do appreciate any feedback from GPs via the channels outlined in these slides. Feedback, complaints and clinical incidents are discussed at the quarterly Antenatal Share Care advisory meetings. I'll hand it over to you, Mel.
All right, thanks, Alex. Can you hear me okay?
Perfect, thank you.
Great, thanks. Hi, everyone. Thanks for joining. My name is Melanie Tulloch, and I'm the Clinical Midwife Consultant for GP Shared Care at Sydney Local Health District, also known as the GP Liaison Midwife. So I'm your main point of contact at Canterbury Hospital and Royal Prince Alfred Hospital Maternity Services. I'm here to provide non-urgent clinical advice to GPs and assist with referrals and all sorts of other inquiries. If you need urgent or after hours clinical advice, or you feel like you need to speak to a doctor, please contact the obstetric registrar on call through the hospital switchboard, or send your patient to the emergency department or EPAS if they're experiencing pain or bleeding under 20 weeks gestation. I carry a mobile phone specifically dedicated to answering GP inquiries. It is for GPs only, so please don't give that number out to patients. I currently work part-time Wednesday to Friday. On Mondays and Tuesdays, my phone is diverted to my manager, Tara. So together we're available for advice Monday to Friday, 8 a.m. to 4:30. Happy to help with any type of inquiry. So definitely don't hesitate to get in touch. If you can't reach me, please do leave a message. I generally can get back to you within a couple of hours. So to provide you with an overview of the hospitals we've got in SLHD, so there are 3 hospitals that provide maternity care. RPA is a level 6 tertiary referral hospital with about 4,500 births per year. Women with complex pregnancies can receive care through many specialist clinics, and it has a large neonatal intensive care unit. Canterbury Hospital is a level 4 hospital with around 1,500 births per year, but it still has the capacity to provide care to women and babies with a number of complex health issues and many higher risk pregnancies. When women and babies do need to be transferred to RPA or another hospital for higher level care, there is an established system in place to enable safe transfer. There's also a midwifery group practice based at Concord Hospital, which cares for around 280 women per year. Through Concord MGP, women receive continuity of midwifery care at Concord, and then they give birth at either RPA or Canterbury, supported by the MGP midwife. Women are welcome to book in at any of our hospitals. It's their choice, regardless of which suburb they live in. However, please be aware that programs that involved home visiting can only take families who live within the postcode boundaries of that hospital. So that means that MGP, MAPS and Birth Centre, which I'll discuss in a moment, as well as postnatal home visits, can generally only be accessed by women who live in the hospital's local area. So if you have a patient really wanting MGP, for example, you will need to refer them to MGP at their local hospital for them to have a chance at getting a spot. And you can find a list of postcodes for each hospital on Health Pathways, as well as on the RPA and Canterbury Hospital websites. So we'll take a look at each service in a moment. First, I'm just going to run through the recommended antenatal schedule of care. So you can access a detailed RPA schedule of care, as well as a summary document specifically for GP antenatal shared care on the Resources for GPs page on the CESPN website. So the first time a pregnant patient comes to see their GP, there's obviously a lot of information to cover and tests to order. So please do become very familiar with the Antenatal First Consult Health Pathway and refer back to it regularly. It is a long one, but it covers just about everything you need to go through in that first visit. So key things to cover in that first visit. So you're going to arrange early pregnancy screening tests, including blood tests, a dating scan, talk about first trimester screening or nuptial translucency, NIPT, and consider whether the patient is high risk for GDM and needs an early glucose tolerance test. And please do provide copies of results to the patients. It's a good opportunity to discuss antenatal care options, refer to the hospital. Please ensure referrals are addressed to a named specialist, which is the default option if you do an e-referral, and start a yellow card if you're planning for them to do antenatal shared care. So obviously that's a lot to cover, and you might need to split that visit over more than one visit. Sorry, split that conversation over more than one visit. If there's anything you ever feel unsure of, or you have a particularly complex patient that you need to discuss, maybe an urgent referral, please do give me a call to have a chat about it. So moving on to 12 to 13 weeks, that's around the time we would normally do a first trimester screen, which is essentially a nuptial translucency ultrasound, which you're probably familiar with, but it also includes screening for early onset preeclampsia and fetal growth restriction, plus or minus an NIPT if they want that. And you can find more information in the prenatal screening and diagnosis of fetal and maternal conditions health pathway. Around a similar time, 12 to 14 weeks, is when we aim to do the first midwife booking at the hospital. If they're at RPA, you'll find that will either be one 90-minute appointment with a midwife, or it might be split across two 45-minute visits, depending on the model of care that they're wanting. So at that visit, we obtain a general health and pregnancy history, start a yellow card if they don't already have one. We do a psychosocial screen, including an Edinburgh Depression Scale, refer to obstetrics and any allied health services that they might need, and confirm preferences and availability of antenatal care options. 19 to 22 weeks, that's when they have the fetal morphology ultrasound, also called the FAS or the fetal anatomy survey. And that would be done at a private ultrasound provider, unless they have a very high risk pregnancy, in which case it can be done at RPA. From then on, they have approximately 4 weekly visits until 30 weeks. If they're doing shared care, that will be with you, the GP, or otherwise at the hospital. So every visit from here on in includes a routine clinical assessment. So that includes blood pressure, fundal height, fetal heart rate, and asking about fetal movement. Around this time, you'd refer them for the 26 to 28-week GTT plus the routine bloods that you do with that. If they do develop GDM, please refer them to the diabetes clinic and provide a hard copy of those results to the patient as well. Around 28 weeks is a good time to offer the RSV and pertussis vaccines, and the flu vaccine are relevant as well. And each visit, please just fill out the yellow card. So at 30 weeks, they'll always have a visit at the hospital. So again, that routine assessment, we'll review the GTT results, anti-D if they are rhesus negative, and again, offer vaccines, which they can also access at the hospital if they haven't already had it with the GP. From that point, it's approximately 3 weekly visits until 36 weeks with the GP if it's antenatal shared care. During this time, we'd arrange a 36-week growth and wellbeing ultrasound if required. That scan is considered a routine thing for everyone at RPA, but not at Canterbury. A low vaginal swab for GBS screening at 36 weeks, and we also usually would do a full blood count and ferritin for most people at 36 weeks. The second prophylactic anti-D dose, if they're rhesus negative, takes place at around 34 to 36 weeks. And again, just complete the yellow card. And there is, for reference, the antenatal second and third trimester health pathway. 37 weeks, they'll have a hospital visit. We'll review the results of the ultrasound, blood test, and low vaginal swab. Arrange obstetric review if needed. So, for example, if they've had a previous cesarean, they'd always have a obstetric visit at this point to discuss mode of birth preferences. And we'd also be having initial discussions about any routine inductions that might be there for induction of labour. That includes things like maternal age above 40 or above, BMI 35 or above, or born in South Asia. And from that point, it's visits every 1 or 2 weeks until 40 weeks with the GP if it's shared care, and just the routine clinical assessment and completing the yellow card each time. At 40 weeks, they'll have a hospital visit. We'll offer them a membrane sweep and discuss consent and book a post-dates induction of labour for after 41 weeks. 41 weeks, if they make it that far, they have another hospital visit at which they also have a growth and wellbeing ultrasound around that time. And then hopefully pretty soon after that, they will have had a baby. So postnatally, it's recommended that they see the GP for a newborn check around 10 to 14 days. I know in practice, not everyone brings their baby in at that point, but definitely would be recommending a long visit for a mother and baby check at 4 to 6 weeks. And you can have a look at the maternal postnatal check and newborn check health pathways for some more details there. That's just a brief run through of, I guess, a standard antenatal schedule of care. Obviously, it can be individualised according to that person's needs. If you ever have any questions or issues, please don't hesitate to call me. That's what I'm here for. So you can call me for any non-urgent inquiries Monday to Friday, or you can page the on-call O&G registrar through the hospital switchboard for any urgent or after-hour inquiries. So I'm going to jump into the various models of care, both public and private, that we have in the health district. So there's several different models of antenatal care available to women who are generally well with a low to moderate risk pregnancy. It'd be great if you can familiarise yourself with the National Midwifery Guidelines for consultation and referral. Generally, if you are looking at that document, women with a category A or B risk factors are considered suitable for low risk models of care, including antenatal shared care. Those with category C risk factors are likely to need to receive hospital-based antenatal care, possibly through one of the high-risk specialist clinics. So let's start with GP antenatal shared care. So most women will see the hospital midwife for their booking visit around 12 to 14 weeks, and again at 30, 37 and 40 weeks, as well as seeing the hospital doctors or other services such as social work if needed. So the majority of antenatal visits will be with her GP if she's doing shared care. And again, there is that recommended shared care schedule of antenatal care available on the CESPIN website to refer to. If the woman develops an issue that requires her to come to the hospital for more frequent visits during the pregnancy, a key example is gestational diabetes or intrauterine growth restriction, then she will need to transfer out of shared care to hospital-based care. Midwifery group practice. So that is a midwife or MGP. So this is a midwife-led continuity model where antenatal, labour and birth and postnatal care are provided with a known midwife. There are MGPs at RPA, Canterbury and Concord, and there's also now a specialist MGP at RPA for Aboriginal and Torres Strait Islander women or women having babies who will identify as Aboriginal and Torres Strait Islander. Women receive up to 14 days of postnatal home visits, and they do need to live in the local area, so in those hospital catchment postcodes, to be eligible for MGP. It is a very popular service, so women need to be referred as early as possible, ideally as soon as the pregnancy is confirmed, sort of in that 5, 6, 7 week window. So midwifery, antenatal and postnatal service, otherwise known as MAPS. This is similar to MGP in that women are cared for by a known midwife during the pregnancy and postnatally, but during labour and birth, they'll be cared for by the team in the birthing unit. Antenatal visits mostly take place outside of the hospital at one of several community outreach clinics, and women receive up to 14 days of postnatal home visits, but they do need to live in the local area to receive these. And MAPS can provide antenatal shared care. So if you're doing shared care for someone, you may find that the hospital side of their care is with a MAPS midwife. And then there's the birth centre. So that's a small team of midwives who provide antenatal, intrapartum and postnatal care in the RPA birth centre, including up to 14 days of postnatal home visits. In this model, it's not an on-call model, so a midwife is rostered on 24 hours a day in the birth centre to provide intrapartum care. The physical birth centre is a less medical environment compared to delivery wards. So, for example, there are deep birthing pools in each room. There aren't as many machines in the rooms. So it's ideal for women wanting a natural labour and birth and, of course, having a low-risk pregnancy. It is located just down the corridor from delivery ward with direct access to operating theatres, and it's linked in with the emergency response system. So help is still close at hand if needed. Women will need to transfer to delivery ward if complications arise, including needing continuous electronic fetal monitoring during labour or if they're wanting an epidural. And the birth centre midwife will continue to care for them in the delivery ward. So if a woman has a low-risk pregnancy and is not receiving care through one of the models I just spoke about, then I guess the default care option would be to attend the midwives clinic at either the RPA antenatal clinic or one of several community outreach clinics where they'll generally see the same midwife each time. During labour and birth, they'll be cared for by the team in delivery ward, and after discharge, they may be able to receive postnatal home visits home, but that is subject to availability. If they have a pre-existing health condition or any sort of complication in their pregnancy, they'll have an appointment with a hospital obstetrician sometime after their morphology ultrasound, so around 23 weeks, who'll review their history, confirm suitability for their chosen model of care, and then make a plan for pregnancy, including any extra tests or investigations that they might need. So for women with a high risk or complicated pregnancy, at least some of the antenatal care will be provided through one of the specialist clinics, either at RPA or Canterbury. So there's a number of different specialist clinics. The ones listed in the slide are those that see the largest numbers of women, but there's quite a few of them. Referral to most of these clinics happens internally through the antenatal clinic. So as a GP, you don't need to remember all of these and know which clinic to refer them to. Basically, just refer them for antenatal care as early as possible. Include plenty of detail in the referral, including attaching blood and ultrasound results. We'll triage the referral and book them in with the specialist clinics as needed. The exceptions to that rule are the diabetes, thyroid and genetic counselling clinics. So those clinics do require separate referrals. Genetics, I believe, is now an e-referral, but diabetes and thyroid at the moment are still on paper. And each one has detailed referral information on health pathways. I know this can probably sound a bit complex and overwhelming. Please feel free to call me if you'd like to discuss a complicated or urgent referral. The RPA e-referral system allows you to mark a referral as urgent. Please be aware that it can take the antenatal clinic up to about 2 weeks to triage a non-urgent referral, so do mark it urgent if she needs an appointment in the next few weeks. At RPA, there is also a clinical midwife consultant for high-risk pregnancy. So she has a caseload of women with high-risk pregnancies and works collaboratively with a range of medical specialists, not just obstetrics. You can't refer women directly to her, but GP referrals meeting certain criteria, so detail of fairly complex medical conditions, will automatically be forwarded to her. And we also have a clinical midwife consultant who works with Aboriginal and Torres Strait Islander women, or women who are having a baby who will identify as Aboriginal or Torres Strait Islander, and she accepts referrals through the antenatal clinic. So just a quick note on women with complicated pregnancies who reside within the Canterbury Hospital catchment area. So Canterbury Hospital, it is a smaller level 4 hospital, but it can provide care for women with a range of risk factors in pregnancy, including but not limited to type 2 diabetes, thyroid disease, high BMI, IVF pregnancy, advanced maternal age, hypertension, DCDA twins, previous pregnancy loss, and wanting vaginal birth after one previous cesarean. So women with risk factors often do need to have more frequent antenatal visits. So receiving care close to home can be a major advantage for those women, as well as, of course, being able to receive postnatal home visits. So depending on the condition, women with high-risk pregnancies are often still eligible for continuity models such as CAPS and MGP at Canterbury as well. So definitely don't assume that if you have someone who is higher risk that you need to refer them to RPA. It could really suit them to receive care closer to home. If Canterbury receives a referral for someone with a condition that does require specialist care at RPA, then the referral will just be redirected to RPA. Specific conditions which do require transfer of care to RPA include type 1 diabetes, MCDA, MCMA twins or triplets, if they're wanting a vaginal birth after having had 2 or more previous cesareans, or if they don't have an operation report from the first one, if they're a Jehovah's Witness or declining blood products, and also certain rare medical conditions that would affect the pregnancy. So if you're not sure if a woman is suitable to come to Canterbury, please just give me a call and we can have a chat about it. And then, of course, women can also choose to give birth at RPA or Canterbury, but receive their care from a private obstetrician who is affiliated with the hospital. So please refer women wanting private obstetric care directly to the obstetrician through their private rooms rather than to the hospital. And you can access a list of private obstetricians who are affiliated with RPA and Canterbury on the Health Pathways website. So I also just want to briefly mention some other services that you may want to refer women to in early pregnancy before they have their first booking visit with the hospital. These are the ones, as a GP, you really want to know about. All of these services are located at RPA, but they're also open and available to women planning to birth at Canterbury. So the Early Pregnancy Assessment Service, or EPAS, is specifically for women who are less than 20 weeks pregnant and experiencing vaginal bleeding or abdominal pain. They're open 8:30 to 3:30 Monday to Friday, or you can also contact the EPAS clinical midwife consultant on her mobile if you need advice or you want to discuss whether someone's suitable to come in. Contact and referral information is available on the EPAS Health Pathway. On weekends, or for women who are experiencing heavy bleeding, severe abdominal pain or dizziness and fainting, please send them directly to the emergency department at either RPA or Canterbury. And women who are more than 20 weeks gestation should call the hospital birthing unit 24 hours per day. RPA Virtual Hospital, or RPA Virtual Midwifery Service, they collaborate with Hospital in the Home to provide care to women with moderate to severe nausea and vomiting during pregnancy, with the goal of reducing emergency department visits. So together with HIF, they can provide specialised care, including medication management, IV fluids, follow-up care through telehealth, referrals to different services like dietetics, social work and psychologists as needed. The Fetal Medicine Unit. FMU provides prenatal screening services, so namely the NIPT and the combined first trimester screen, and I know Effie's going to cover those in more detail later. When you submit an e-referral to the Antenatal clinic at RPA, you do have the option of ticking a box, which allows you to also automatically refer them for NIPT and first trimester screen if they want that. Women who screen as high risk for chromosomal or abnormalities will be offered counselling about diagnostic testing like CVS and amniocentesis and specialist input as needed. Please note that FMU doesn't offer dating ultrasounds or morphology ultrasounds, with the exception of people with very high risk pregnancies or who maybe had a previous loss. So please refer women to private providers for those scans. And then there's the ISAIL clinic. ISAIL stands for Integrated Support After Infant Loss. They provide support for women across SLHD who've experienced pregnancy loss. And there's a key focus on multidisciplinary coordinated appointments for women and families following stillbirth, generally above 20 weeks. And finally, there's also a clinical genetics clinic, which can provide preconception and pregnancy counselling for women with a personal or family history of genetic conditions. Clinical midwife consultant Lizzie Austin is available for phone consults and advice about genetic testing or complicated issues. So please feel free to get in touch through her mobile. She's definitely quicker to speak to than a genetic counselling session, so don't hesitate to give her a call. And there's more information on the genetic health assessment and health pathway. So just briefly, a couple of things about referrals. So Hannah will cover how to actually submit an e-referral in a moment. I'd just like to cover a couple of key pointers about referrals to the hospital. So please attach all pathology and ultrasound results to the referral, because this really allows us to accurately triage it. Please mark the referral as urgent if the woman is above 16 weeks, if there's psychosocial concerns or a medical condition requiring a review in the next few weeks. If you do mark a referral as urgent, you'll be prompted to make a phone call to someone at the hospital. So that means either calling me, the GP liaison midwife, or the O&G registrar to discuss. Women who are referred to MGP but miss out, unfortunately there are quite a lot of them, will automatically have their referral reviewed by an alternative midwifery continuity model like MAPS or Birth Centre. And if you're unsure about what service is most suitable for a particular woman, if you want to flag an urgent referral or need me to help chase up a referral that you're not sure where it's gone and she's still waiting, please don't hesitate to call me. And finally, I just want to briefly cover what communication you can expect to receive from the hospital to keep you in the loop when providing antenatal shared care, and also what we ask of you as well. So the yellow card, obviously when we don't all share a common electronic medical record system, that always presents communication challenges. So the yellow card, it's old fashioned, but it's still a really essential method of communication between the hospital and GPs providing antenatal shared care. So please do fill it out at every visit. Electronic discharge summaries. So we generate discharge summaries after every midwife booking visit, most obstetrician visits, and also visits to EPAS and ED. And maternal and neonatal discharge summaries are completed on discharge home from the postnatal ward or the NICU. Unfortunately, there is a fairly long-standing statewide issue with discharge summaries not sending electronically to the GP through HealthLink as they're supposed to, and that hasn't yet been resolved. So in the meantime, we're providing hard copies of the postnatal discharge summaries to the woman on discharge home from the hospital and asking her to bring them to the first postnatal visit with the GP. If someone turns up for the 6-week visit and you haven't received a postnatal discharge summary, or you know they've had a complicated birth, please just give me a call so I can fax one over to you. And then finally, copies of New South Wales Health Pathology and FMU ultrasound reports. So pathology results should appear on My Health Record, and FMU ultrasound reports are sent electronically to the referring GP. We do continually educate hospital staff also to copy in the GP, the shared care GP rather, when ordering external pathology like the glucose tolerance test, only if they're doing shared care. All of this does rely on various IT systems that don't always work as they should. So if you need help obtaining results, you feel like they should have come through and you haven't got them, again, please just give me a call. Hospital staff, I think goes both ways. We probably all spend a lot of time chasing results ordered by the other clinician. So if you order some results, please do give your pregnant patients a copy. It just makes life a bit easier. So I want to end my presentation by acknowledging that GPs are a really key part of the antenatal and postnatal care team, and we'd like to work as collaboratively as possible. So please don't hesitate to call me if you need assistance with clinical advice or referrals or anything really. And I encourage you to leave feedback for the hospital through any of the mechanisms that Alex covered earlier. And I look forward to working with you. Thank you.
Thanks, Mel. Just confirming, can you all hear me clearly? Or Mel, could you give me a nod? Yes, perfect. All right.
Yep.
Hi, everyone. I'm Hannah Coffey. I'm the e-referral project officer for Sydney LHD. First of all, apologies. My camera is not working this evening. But I am presenting on behalf of my broader team, or the broader e-referral team, including my colleagues Paul Bennett and Lauren Walker. So I won't go through a full demonstration of the HealthLink Smart Form platform tonight, as we are tight on time and most GPs are fairly familiar with the platform now. However, I have included a link to a short YouTube video which we recorded last year, and it specifically goes through how to access and submit electronic referrals for maternity services at RPA, Canterbury and Concord Hospital. So this video is available via the link and the QR code. Tonight I just want to go through a couple of new and key features for the platform that are specific to our maternity and women's health referrals. So as most of you will be aware, the HealthLink Smartform portal is available via your practice software, so Best Practice, Medical Director, Genie, etc., and also via the HealthLink portal if you aren't using an electronic medical system. Sydney Local Health District electronic referrals are listed within 2 folders as highlighted on the screen. If you can't see those folders on your HealthLink homepage, you'll need to contact HealthLink directly. So they're chosen or essentially visible. It's dependent on the practice. In saying that, HealthLink are very responsive. So if you get in touch with them, and I've got their contact details on a slide coming up, they can normally update your practice access and within a few hours. Please note, it is a little bit confusing. I do apologise. We do have those 2 folders. We're working on combining them all into one. So please keep an eye out on PHN newsletters and updates over the next sort of 12 to 18 months as more and more of those forms get moved over to one folder. I won't go through all the details, but keep an eye out on the communications for that. So we have over 85 Sydney LHD services now accepting electronic referral forms as listed on the screen. I've specifically highlighted all of the women's health services, and we'll flag specifically EPAS down the bottom there at RPA, and also women's ultrasound and fetal medicine at RPA. So there are 2 newer services to come on board with or from Women and Babies at RPA. I will note as well that we'll have a huge influx of services from RPA in the next 2 months towards the end of May. So essentially every outpatient service at RPA will be online with electronic referrals as well. We'll then move on to Concord, Balmain, Canterbury hospitals, as well as all of the community health centres. So essentially by the end of 2026, essentially every single Sydney LHD service will be online with electronic referrals, which will hopefully make your lives easier as well. Some clinics are stepping away altogether from the receipt and processing of other referral methods, so email and fax. So I do encourage you to familiarise yourself with the HealthLink electronic referral platform if you haven't already done so. As most of you would be aware, the benefits are it's secure electronic transmission of referral documentation. Patient information is automatically brought across from your practice software, saving you guys a whole lot of time. There's a specific tab on the form submission for attachments, including pathology and imaging results, etc. And please do remember for these antenatal referrals to attach the relevant pathology results. And then also on submission, you'll receive an acknowledgement back to your system that the referral has been received by the service. You'll also receive messages on the triage outcome of that referral, and also triaging clinicians can communicate electronically with you if they require information to safely triage. So, sorry, just the previous slide, Alex. Specific information about requesting first trimester screen and NIPT. So for women birthing at RPA, when you refer them via the RPA Antenatal electronic referral form, you can request first trimester screen and NIPT as a part of that referral. Just tick yes to both of those boxes, or yes to either or both, and the patient will be contacted by the FMU team to book in those assessments and tests. You don't need to complete a separate FMU referral form. As I mentioned in the previous screen, there is a separate referral form now for requests. So if you do have any of those old tear-off FMU referral, please throw them out and start using the HealthLink Smartform. Next slide. Thanks, Alex. I also want to flag the update referral feature that's now available. So this came out about halfway through last year. Please note that it's only available for referral forms that sit within that Sydney LHD Women's Health and RPA Gastroenterology Services folder. So that's where we're moving all of the other services across to. So hopefully you'll be able to make updates to more and more of your Sydney LHD referrals in the coming months. The update referral feature can be accessed by going into the HealthLink portal from your patient's file. There's a tab up the top which says Update Referrals, and within this tab you'll see the status of all of the HealthLink referrals for that patient. If that referral is still active, i.e. the status is received, awaiting triage or post-triage admin, you'll be able to make updates to that referral, either in the form of free text, as you can see by that bottom box on the right, free text, or adding attachments. So understandably, or I hope you can understand, so that update referral feature is only available, as I mentioned, to referrals that are still active. So you can't make an update to a referral that you sent 6 months ago that's already been processed. It's more for those referrals that are still in flight. And this feature, I think, is very, very handy for our antenatal referrals. Essentially, send off that initial referral as soon as Mel mentioned, and then come back to the result, or if the patient, has a dating scan the following week, you can add that in afterwards. Similarly, if the triaging clinician has requested further information or sent a message back to you saying, this referral is on hold, please send through X, Y, and Z, you can utilise that update referral feature to provide that information. Next slide, Alex. I've included a table here which details where copies of the referral are saved within the patient's record for each of the different practice software. I will note that for some of the software, and I apologise, I can't remember off the top of my head whether it's MD or best practice. For one of those, you do need to save the encounter. So essentially, this hasn't been a problem if you are, sending off a referral with the patient sitting in front of you during that consult. That will automatically be saved because you'll generally be saving that encounter as well. But if, for example, you are flicking off an e-referral later on in the day or in the evening or whatever it might be, we recommend that you do still save that as an encounter within your best practice software or medical director software, just to ensure that PDF is saved. Just had a few GPs indicate that they've finding copies of those referrals. And then finally, next slide, there are some active links. I think Alex is going to send out the slides to you all after the session. There's some active links here to the PHN website, Health Pathways Sydney GP referral project page, and there's also some individual quick start guides for your practice software, which are really useful, and they've got those step-by-step processes to updating referrals, which is a new feature as well. If anyone doesn't have access to HealthLink, there's also the email address there, so you can register. And finally, just our contact details. So again, HealthLink details there, they're very responsive. And digital health team and also my team. Please don't hesitate to contact us if you have any questions or you're having any issues with the HealthLink platform. We're available for practice visits as well if you require specific guidance or support. Thank you. I've whisked through that. Please feel free to pop any questions in the chat and I will try and answer them. Thank you. Over to you, Effie.
Thanks, Emma.
Thanks, everyone, and thanks, Hannah. I hope you can hear me okay. The thing that Hannah mentioned about going back and adding, it's mostly used for the midwifery group practice because patients ask for early referrals, and you often have to refer so they get in line, and then you order the bloods and that and add it in later. So you'll see it as you begin your practice in shared care, which I welcome you to. The next few slides are just going to illustrate the differences between simple nuchal translucency offered by your local radiology practice and the more specialised services. And we'll clarify it with some examples. Next slide. So we use these three modalities in screening: the maternal history, ultrasound markers and measures, and some biochemical markers are collected off the mother. Next slide. The risks we know and can assess is, the maternal age, as you can see from the graph, Increasing age increases the risk of trisomy. And also the graph shows the nuchal thickness increases the risk. The non-invasive markers, for example, PAPA, low levels can be associated with trisomy. The ultrasound markers, as we said, the nuchal translucency, we look at nasal bones. Uterine arterial pulsatility index can be a marker for preeclampsia and growth restriction. And the fetal DNA we use in the NIPT test, and our assessment is a combination or, parts of these. Next slide. So this is a pared down nuchal translucency screen to assess risk done by local radiology practices. They use the maternal age, the ultrasound markers, which is the nuchal fold, and they measure PAPA, pregnancy associated plasma protein A, PLGF, plasma growth factor, placental growth factor, and free HCG, and they get a combined risk assessment, which is best seen with an example on the next slide. So this is a 27-year-old school teacher who presented to our practice at 13 weeks. So we sort of struggled to get an appointment for her anywhere. So basically the findings are singleton pregnancy, crown rump length and estimated size. The nuchal translucency was 1.98 millimeters. So that's, a good finding. The biochemistry is added, and the radiology practice puts together a combined risk assessment, which you can see is, low risk for trisomy. Next slide shows a picture of the scan. So you can see the nasal bones are labelled at the top. The amniotic fluid pocket is behind the nuchal fold, where you can see the two crosses just above it. So, it's a little bit deceptive, and you could think that's a really thick nuchal fold, but it's amniotic fluid. The report didn't mention the nasal bones, but their presence is, reassuring because their absence is linked to trisomy 21. Next slide, yeah. So the combined first trimester screen uses all that information plus more that is gathered from obstetricians that work in this area with advanced skills. So we add in, BMI measures, background history of, inflammation, whether they've got lupus, all sorts of things to come up with a risk assessment, plus all those markers. And they also measure the blood pressure in the mum and the uterine pulsatility index in the placenta, and come up with a risk assessment for preeclampsia. And using all these can predict 90% of patients at risk of preeclampsia, and 1 in 100 is the cutoff, and below this we give aspirin. And aspirin is thought to inhibit the spiral arterioles in the placenta and reduce the risk. Next slide. This is an example of a 35-year-old PRIMIP patient who had a risk assessment. This one was done at Sydney Ultrasound for Women, and I've put it on because it's 1 page, whereas the RPA ones can be 3 pages long and extremely detailed. So just to illustrate the sort of readings that we get, that you can see anatomical detail, and we can see the nuchal fold measure is 2 millimeters. Next slide. And this is the sort of answer you get with the trisomy risk and the interpretation, and the mean arterial pressure, which is the mother's blood pressure, and the uterine artery index, and her risk for preeclampsia is 1 in 618. And so, you know, she's deemed a low risk pregnancy and is followed up appropriately. On the next slide, we have an example of a higher risk pregnancy. This lady was 44 years of age, which is her high age-related risk of 1 in 30 for trisomy 21. But adjusted with her bloods and her measures, she's now low risk for trisomy. But her mean arterial blood pressure was higher, and her preeclampsia risk was high, 1 in 36. So she was actually commenced on aspirin immediately, and she did not get high blood pressure in the course of this pregnancy. But she did get postnatal high blood pressure and was on medication for a couple of years after delivering a very precious baby at age 44. Next slide. So when we look at NIPT, we basically don't use any ultrasound markers, not much in the maternal history, and it all centres around peripheral maternal blood collection and fetal DNA that is found in it. Firstly, you need to confirm that it's a viable pregnancy. So I normally tell my patients to have a scan just prior to collection at roughly about 10 weeks, because the worst thing is to have you know, fetal demise and then send them off for a blood test. So we extract the DNA, and it's got a 99% accuracy rate, and tells us about the risk of trisomy and aneuploidy in the sex chromosome. So we'll have a look at the next slide for an example. So it's often reported in this way. So chromosome 21, 18, 13, low probability with 2 copies, and the sex chromosomes. So this is a female, and both of those 2 previous cases had this result. They both had little girls. So next slide. The way I would look at it is if we can get our patients to have a combined first trimester screen where we get the trisomy risk and the preeclampsia risk, then we can streamline them into a lower risk pregnancy. Whereas a higher risk combined first trimester screen, we can add in the NIPT, and then if concerned, if an abnormal result, we lead on to more invasive tests that have a risk of miscarriage, such as amnio and CVS testing. So in conclusion, yeah, the best risk assessment is the combined first trimester screen. RPA is well staffed and can take their appointments. There's also private places that can have them done, and they've been included there. So they're specialised ultrasound services, and you know, it's worth having a look at the websites to know the cost. They kind of sit around the $400 mark, which is comparable to the NIPT test as well. Okay, next slide. So we'll go through looking after a pregnancy, I think best seen with cases. So on the next slide, we'll detail a bit of the first visit, which often takes a couple of sessions to go through. You need to get familiar with the Health Pathways first visit. It's got a lot of information. Everything you click drops down into more information, which is very helpful. And as you go, you'll find your own way of asking questions. So asking about family history, you know, for example, where there's consanguinity, you know, in certain you know, ethnic groups, asking about whether kids have, you know, special needs or go to special school, you know, whether that appears in their family tree. I would draw your attention to the pathology tests. Thalassemia screening sometimes gets forgotten amongst all the new stuff. There's a high prevalence of carrying this in Sydney's inner west. So there's something like about 1 in 15 would carry it. And if a female is positive, the partner should be tested, especially in communities that intermarry. I work in Earlwood, which is very Greek and Mediterranean, and, you know, we need to know this sort of stuff. And so there's all these little pockets in the inner west, so get familiar with it. The 3-gene reproductive carrier screen only needs to be done once. It doesn't need to be checked every pregnancy. The patient will get charged, so, you know, ask about this one, okay? We'll get with the next slide, which will do our case, which is Kathy. She presents age 39 at the first pregnancy, and she's concerned because she's had a little bit of spotting. It followed intercourse. It wasn't painful, but, you know, it's a precious pregnancy. It's her first one at this age. Interesting in her background is mum's got hypothyroidism and type 2 diabetes. So that's something to keep in mind when we assess her for GDM risk. Next slide. We examine her. She examines well. Her abdomen is soft. You know, she's got normal BMI. Next slide. We start a pregnancy record and we organise some bloods for her, including a HCG, and we refer her on for a pregnancy dating scan and refer her to the antenatal clinic, and we can add in all these results for later. Next slide. So this is her dating scan. And we've basically got single pregnancy. The crown rump length is 8 weeks, and they could hear the fetal heart rate. There's a small bleed around the gestational sac, which we'll see on the next slide. So the left picture is a close-up of the crown rump length, which is 16.4 millimetres. And the picture on the right, the sac is within the uterus, and there's that small bleed at 5 o'clock that has been marked out with the markers there. So that's a really small amount of blood, and that will get reabsorbed and is, you know, extremely low risk for miscarriage in this pregnancy. Next slide. So the next visit, Kathy comes back for her results and a review. So she's feeling nauseous now. There's not been any more spotting. She's having a bit of a time with the nausea, and she's lost a little bit of weight. And otherwise she measures okay. Her bloods are normal except for her thyroid, which we show on the next slide. She's got a raised TSH, and she's got positive TPO antibodies, which is basically Hashimoto's, but, you know, while pregnant. And so we have to treat this to get her TSH in the normal range. And every lab has specific targets in pregnancy, and you should aim to treat for those targets. Next slide. So I started her with thyroxine, just a low dose. We filled in a yellow card. So yellow card, it's an A4 size, bit of writing to do. And we talked about genetic testing for her. And, you know, she was of the feeling that at 39, if she had a trisomy pregnancy, that she would terminate. So she was very interested in having both combined first trimester screen and NIPT done, which we arranged for her. And we also arranged an early glucose tolerance test because of a higher risk for gestational diabetes. So we'll see on the next slide. This is the Health Pathways Risk Assessment. So she's going to be aged over 40 at time of delivery, and the family history, her mum is diabetic. Like, you only need one risk factor from the left-hand column to, need an early GDM screen. I'm a little bit OCD about doing these things. I give her the pathology form, and I'll actually put the window of time on the back so she knows exactly when she needs to do it. And, we line it up at 16 to 18 weeks, and we go from there. Next slide. So Kathy had a NIPT test, which is low risk, and she asked not to know the gender. And she was also low risk for preeclampsia on her scan. We gave her these results over telehealth because this was actually a pregnancy that occurred during COVID, lockdown. We just go over her symptoms. She's got her first visit booked, and we remind her to do a glucose test. Next slide. Oops, yeah, this is her results. Sorry, I think I got them out of order. So she's low risk for trisomy, and it's actually female, and she didn't want to know the sex, so we keep that from her. Her preeclampsia risk 1 in 900, so low risk there, so very reassuring. Next slide. So she's come back after her blood tests, and we've checked her thyroid and done a glucose screen. RPA have asked that we check her thyroid every 4 to 6 weeks, and this is basically because things change quicker in a pregnancy. You don't wait the 3 months you would in general practice. So we organise her next test and give her a form so she's ready to go. Her TSH is still slightly elevated, that you can see, and the target would be below 2.5 in this stage of pregnancy. So we'll go to the next slide. Her GTT is normal, so there's no diabetes on the early tests. So I opted to double her thyroxine to 100, and her next blood test will be in 4 to 6 weeks, and we give her the pathology and go from there. Next slide. So she's had her second lot of bloods done. She's now 21 weeks, and she's also had her morphology or fetal anomaly scan, and everything's normal apart from the placenta being 3.5 centimetres from the internal os. So this will need a follow-up later on to see how close the placenta is. We can see her next lot of bloods now are to target, and so we continue at the same dose of thyroxine. And we remind her that she needs the thyroid function tested again, and we'll do it with the glucose test. And we also repeat her syphilis serology, because we like to test it twice in the pregnancy, because there have been, heartbreakingly, some women that seroconvert during the course of a pregnancy. So we need 2 tests in the pregnancy initial, and this is an opportune time. Next slide. I also urge you to measure, make sure you palpate the fundus. If you've got an office Doppler, have a listen, and to record in the yellow card So, you know, keep practicing, keep palpating, and you'll get better at it. Next slide. So these are results of the second glucose test. So it's still normal, and her further thyroid testing is also normal. So these are all good results. Her syphilis test was also negative. I didn't include it in the slide. Next. So she comes back for a visit. We check her. She's putting on weight nicely. Her blood pressure's good. We examine her, and you can see her fundal height is a little bit below what I'd expect. But she sort of, the lie is a bit longitudinal with the head felt high in the right upper quadrant and a breech presentation, so I'm not that concerned. So we use this opportunity to vaccinate for Boostrix, to give a pertussis booster so that the baby can be protected. And now the RSV vaccine has also been introduced to be given to pregnant women. And there's a little refresher about RSV on the next slide. So RSV, there's two vaccines, and the one for pregnant women is called Abrysvo. And there's another one called, it's got a weird name, Arexi or something like that. So only Abrysvo, so think B for baby, that's the one you give for pregnant women. It's the only one with the B in it. It's a single dose given from 28 to 36 weeks. It's safe to give from 24 weeks, but they don't have data before that about seroconversion and protection. You can give it at the same time as a pertussis, flu and COVID. So they're completely safe to give combined with other vaccines in the timing. The vaccine comes as a powder and it contains the recombinant RSV envelope protein called glycoprotein F. It's represented in the picture as the little purple, thingies on the cell membrane. And further down, it's actually this protein extends, attaches to the target cell and becomes a way of entering the cell. So if we can make antibodies to this, that, will be protected from it. So the protein needs to be mixed with the water dilutant, and it's got a little vial adapter in the box. The most common side effect is a local reaction in the first few days with redness, a bit hot, a bit swollen, and headaches and myalgia. So the usual, paracetamol, cold pack to the arm to treat this. Immune responses start within weeks, and transplacental antibody transfer increases over time. And baby would get adequate protection within about 2 weeks. But if delivery happens in less than 2 weeks, there's a monoclonal antibody to protect the baby. And the whole idea of this is to protect the infant, because the babies under 2 years of age are most at risk of severe RSV requiring hospitalisation and, complicated respiratory presentations. So the season seems to be April to September. So, it's our patients that are coming up now. But I think, we see RSV all year round. So, it's going to fall to us, the GPs and the midwives, to give this and to convince our patients of the advantages of having it. Next slide. So Kathy's now 33 weeks. Things are going well. We examine her again, her weight's good, the blood pressure's good, and she's now cephalic in presentation and is measuring well. We do a Edinburgh postnatal depression screen on her, and she's low risk. We organised some blood for her, including a thyroid function and a swab, and we review the results of her obstetric ultrasound. Remember, she had the placenta close to the os, and it's now 13 centimetres. So all this is doing well, yeah, I think we'll finish the case there because, yeah, that was all the interesting parts for her. So everyone, roll your shoulders, have a stretch, and we'll do one more case before we sort of wrap it up. All right, so this case is Rena. She's a young 23-year-old, and she was seen by my registrar. She was diagnosed at 5 weeks, no kidney issues, no thyroid issues. She's a smoker, and the registrar wrote no consanguinity in the notes. I would actually ask you to, ask the patient about the ethnicity. So if you remember in the gestational diabetes screen, it's the types of ethnicities are more important for risk. So he's also examined her blood pressure's fine, her BMI is 28.7, so we'll revisit that when we screen her for diabetes risk. He's arranged some bloods, a dating scan, and I think the bloods are okay except for the cholesterol, which is a pretty useless test in pregnancy. I think if he got the patient fasting, I'd rather he did a sugar and an A1C. And I usually only do EUC-LFTs if there's abdominal pain or vomiting. But again, I'd encourage you to look at the first visit and, follow the advice given on that page. Next slide. So Rena has a follow-up telehealth visit, which is basically going through her results. She's tried to cut down her smoking. I think I took this phone call and I actually said it's associated with fetal growth restriction and premature births. You must stop. There is no alternative. And I forwarded her Mother Safe information sheet. So there's some really good information sheets on the Mother Safe website. So again, a good resource for shared care GPs. Her results showed a low level of vitamin D, it was 26. And I asked her to take 2 tablets a day. And all else was pretty normal. We find out she's Lebanese, and she's never had a pap smear, which at 23, it's pretty typical. Here we start at 25. We discussed the risks of trisomy, which are low at her age, but she was keen on an NIPT because she wanted to know the sex of the baby. She wasn't interested in the combined first trimester screen, so we organise a scan and the bloods for her. So next visit. This is her NIPT result. So her gestational age, singleton, the percentage of fetal DNA. Her trisomy 21, 18 and 13 risks are low, but she has a sex chromosome aneuploidy, which is XXY. So this is a genetic disorder otherwise known as Klinefelter syndrome. Next slide. So we follow up with a phone call to see how she's going and to give her this news. And explain that it's associated with some feminization of male. They're often tall in stature and have reduced fertility and sometimes have developmental delay. And we organise for her to see a geneticist and further testing, because she, I recommended that she have a CVS or an amnio. This is one where I couldn't get hold of the genetic clinic, and the midwife gave me a different phone number. The liaison midwife gave me a different phone number. So yeah, a really good resource there as well. I also got the patient some good information to have a look at about Klinefelters, because the worst thing you can tell them is to Google it, and we can't rely on Google giving them good medical information. So this is, again, somewhere where GPs can help the patient. Next slide. So Rena comes in for a visit, and this is where I finally get to meet her. She spoke to the genetics people who offered her a CVS, but she was unwilling to risk a miscarriage. Her morphology scans booked. We examine her. Her weight is about the same. We can measure her fundus. We can hear the fetal heart rate. She's having a bit of reflux, so we give her a PPI option, but she prefers to try some Rennie first. Her blood pressure is a little bit high, so we let her have a rest and check it again, and it's okay. And so because of the raised BMI and the Lebanese background, she's at increased risk, and we organise an early glucose tolerance test. Next slide. And you'll see, just a reminder, she's on the moderate risk. The two options, Middle Eastern and a BMI of 28, puts her into the higher risk. So 2 on the moderate side or 1 on the high risk side. Next slide. So this is her result. She's 5.1 at fasting, 6.9 at 1 hour, and 5.4. So it kind of looks pretty good, but not if you're pregnant. Next slide. Just to highlight, the 5.1 is 0.1 above the normal, and she's consistent with gestational diabetes. So at this point, she isn't suitable for shared care. We refer her to the diabetes in pregnancy clinic, and again, refer to health pathways at the best way to refer, because every hospital is just ever so slightly different. Next slide. So we give her these results. She also still had low D, so we increased her dose in that. We explained to her that she will need endocrine care in her pregnancy. We organise her fetal anomaly scan, and we make those referrals. We explained to her that we're still her GP, but the majority of her antenatal care will be done hospital-based and not in the GP setting. Next slide. These are some useful websites for GPs. Of course, Health Pathways. I think you'll be sick of hearing us saying it. The CESPN website, especially the antenatal and maternal and child pages. MotherSafe, the RPA website. For patients, Pregnancy, Baby, Birth, and Raising Children as a parenting website. There was one thing I forgot to mention a bit earlier. With Medicare, there's an item number 16591. This exists and can be claimed once per pregnancy, and it's done after 28 weeks. And this is where you screen for domestic violence, drug and alcohol, and depression. And the fee, the rebate is $162 the last time I checked. So please use this number to show that you are aware of it, that you're doing the care, you should be remunerated. And it also, I think, using the antenatal item numbers shows that, you know, GPs are doing it and they'll get funded. Next slide. Okay, these are all those important contact numbers that I'll hand you over to Alex for. I think that you've got the next slide after this. The shared care midwife liaison is your best contact if in doubt. Thank you from me.
Thank you so much, Epi, and thank you everyone for attending the session tonight. I will be in contact with you in the next few days for the session's resources, and you'll receive a letter of confirmation of meeting all registration requirements in the next few weeks. If you have completed the online first trimester screening module and sent through your certificate, I will update your status this week and you'll be able to provide antenatal share care to patients birthing at Canterbury and RPA hospitals. If you haven't completed this module, I would urge you to do so as soon as possible, and I'll be sending out the updated GP list to the hospitals in the next fortnight. Please remember that the Antenatal Share Care newsletter is sent to your emails quarterly. This is our main form of communication. Only recognised antenatal share care GPs should be undertaking an antenatal share care consult. If you're away, please refer to another recognised antenatal share care GP within your practice or contact the hospital for a one-off visit. Reinforce with the practice manager and staff that women opting for GP antenatal share care must only have antenatal appointments attended by a recognised antenatal share care GP. If in doubt, Health Pathways or the CMC midwife Mel Tulloch. Please, we really do value your feedback. So please, if you have some spare time, complete the evaluation survey in the link here or scan the QR code. Thank you again for attending tonight. I hope you all have a lovely evening. I don't believe there are any questions in the chat, so we will sign off now. And thank you to Mel, Hannah, and again, Effie, for your input in this session. Have a lovely evening. Bye, everyone.